Good afternoon. It is the 13th of September 2020. The time right now is 1:30 p.m. in Delhi. This video would be dedicated to my schoolmate and my childhood friend Rupinder Singh, who went on to major in chemistry and history at the St. Stephen's College, Delhi University. Following that, he also did a physical education fellowship in England. And currently, I would rate him as one of the most mature and best informed athletic coaches. His specialty is long distance running. He himself was a champion Delhi University long distance runner and also a cross country champion. In his time, he was one of the best long distance runners of the city. He was 2 years my senior. And I mention him because he would be really tickled by the fact that now we have data on COVID-19 in sports persons. Now, I have already mentioned one study which was published some weeks ago in JAMA. This was from the University of Frankfurt. This was a cardiac MRI study which took 100 people who had survived COVID-19, who had mild to moderate symptoms. 2/3 of these people were tackled at home. 1/3 needed hospitalization. The MRI was done more than 2 months after the onset of symptoms, and these 100 patients were compared to 50 risk factor matched controls and 50 healthy controls. The risk factor matched controls means that these were people of the similar age bracket with diabetes or hypertension or high cholesterol, but did not have COVID-19. The results were quite stunning. Almost 2/3 of these people who had survived COVID-19 with a mean age of about 49 years had ongoing inflammation in the form of edema in their hearts. And this was confirmed by abnormal elevated T1 and T2 levels. On the cardiac MRI, 20% had pericardial infusion and 30% had previous scars suggested by late gadolinium scarring. Now, the implications of this study are still to be sorted out, but the fact remains that a large proportion of people who have mild to moderate COVID-19 do happen to have changes in their heart, which are picked up by a cardiac MRI and which suggest that there is ongoing lingering inflammation in the heart. Now, this study was also corrected by the researchers because some criticisms were pointed out, some flaws were pointed out, and the corrected version again concludes that the mean age was about 49 to 50 years, and these people did have slightly dilated hearts as compared to controls and slightly reduced ejection fraction as compared to controls, and 2/3 of them did have abnormal native T1 values and abnormal native T2 values, suggesting that there was lingering inflammation. Now, this study is important because some people consider that this is probably the most important study in cardiology in the last 10 years. Now, that is saying a lot because there are a lot of research going on in cardiology, but this particular paper has been downloaded more than 550,000 times, which makes it easily one of the most important cardiology papers published in the last 10 years. Now, coupled with this, there is another paper which has been, it is not a paper, but a research letter which has been published 2 or 3 days back, also in JAMA. This is from the University of Ohio. The lead author is a researcher called Dr. Saurabh, I think, Rajpal, and of course the principal investigator is the director, the physical director of the University of Ohio. They have taken 26 young athletes from the University of Ohio who suffered COVID-19 as confirmed by a PCR test. Of these 26 athletes, 1/4 had no symptoms at all. The mean age was 19 years. And the important finding was that 15% of these athletes, that is 4 of these athletes, had an abnormal T2 value suggesting ongoing inflammation and edema in their hearts. And apart from this, 8 more had scars picked up by a late gadolinium enhancement, which meant that almost 30% of this group of 26 top athletes had previous myocarditis. The ramifications of both these studies are still unclear, but what is certainly required is that we need more studies to evaluate and assess the long-term implications of COVID-19 on the hearts of people who have been infected. Because the problem is that if you have a lingering infection in the heart, then there is always a chance that you might go on to develop heart failure. You would go on to develop a dilated heart, apart from the fact that you would be vulnerable to dangerous arrhythmias, which can lead to sudden death. Now, sudden deaths are rare in sports people. The prevalence in America is about 1 in 15,000 leisure runners. This means that this is a group of middle-aged or elderly people. So therefore, the incidence of 1 in 15,000 is unremarkable. The chances of having a sudden death in marathon runners is about 1 in 50,000. And the chances of sudden death in young people in colleges and universities is as low as 1 in 100,000 to 1 in 200,000. So the incidence is very low, but still a death in a top athlete, in a young person who is seemingly very fit, is a horrendous experience and is definitely a very sad story. But we do hear of elite athletes suddenly dropping dead. We hear of footballers, we hear of athletes, we hear of track athletes who have dropped dead, though rare. But the point is, one has to be aware of this phenomenon. Now, autopsy reports have shown that young people who die suddenly, the majority of them, that is almost 35% of them, have a disease called hypertrophic cardiomyopathy. 15% of them have abnormal coronary artery connections to the heart. This is called coronary artery anomalies. The arteries originate from an abnormal position and then are susceptible to damage and squeezing by the heart itself. And about 5% of these deaths, sudden deaths in young people, are due to myocarditis. 5% are because of channelopathies like long QT syndrome, short QT syndrome, the Brugada syndrome, and 5% are because of right ventricular cardiomyopathy. But for your interest, we will talk about myocarditis because, as I've already mentioned, this research letter, which has been published a few days back, just about 3 days back in JAMA, is suggesting that in their cohort of 26 top college athletes, these were footballers, basketball players, soccer players, track athletes, 15% had ongoing inflammation, despite the fact they had survived COVID-19. The important thing is that these 26 athletes, 25% were asymptomatic, completely asymptomatic. None of them had an abnormal ECG, none of them had an abnormal echo or raised troponins. They were subjected to a cardiac MRI after an informed consent, and the MRI was sensitive enough to pick up these changes in the heart. So it is, of course, known to sports officials that, as also by most, if not all, cardiac societies, that if a person has been found to have myocarditis, it is best that that person refrain from serious exercise for the next 3 to 6 months, because there's always a chance that the myocarditis could trigger off a dangerous arrhythmia and result in sudden death. Now, the European guidelines also suggest the same, that if you have myocarditis and if you are a survivor of any myocarditis, you must not get back to aggressive competitive athletics for 3 months. The American College of Cardiology presented some guidelines in view of the COVID-19, in May this year, which said that if you had COVID-19 and you were asymptomatic, you could resume graded exercises after 2 weeks of convalescence. If you had mild symptoms, then you would need to be checked by an ECG, by an echo, troponin, and if possible by a cardiac MRI. And again, if these were negative, then you would go back to graded gradual resumption of training. If they were positive, then there had to be suspension. You had to stop. Again, because of this risk of sudden death. Now, the implications are many. The Americans are very passionate about their American football. They're very passionate about the inter-college football competition, which has been temporarily paused. But because of the clamor for resumption of American college football, I think the universities and the colleges and the sporting administrations have agreed to relaunch the inter-college football program in a month's time, despite the fact that this study has been published, despite the fact that in case a young athlete in his teens or in his early 20s has a lingering inflammation in the heart, that person could be vulnerable to sudden death. But of course, there is always the fiscal connection. There is always dollars intersecting with sports. So the college administrations, the financial committees, the corporations, the television channels have little regard for the young folks who will actually participate in these inter-college football games. The point which I am now directing is that the IPL is also to begin, I think, in a few weeks' time. And again, in the IPL, we have top cricketers of the world who are participating. Most of them are in their 20s. Some of them, of course, are in their 30s. But it would be wise that if the concerned officials are wary of a lingering myocarditis, it would be highly recommended that in the event of a cricketer who has been found to be PCR positive or has antibodies to the China virus, that such a person is subjected to a cardiac MRI, apart from, of course, an ECG, echo, and troponins, to pick up a lingering or an ongoing inflammation in the heart, because the results could be catastrophic. It is not mandatory that such a person would have a problem, but the results could be very disastrous. And I'm sure the organizers have the fiscal muscle, they have the money power to get the cardiac MRIs done on these cricketers. Now we move on from the sports with COVID to the scenario in Delhi. The scenario in Delhi, despite the scaremongering increase in the number of cases, is pretty good, because as I mentioned, we had a serological testing done 1 month ago. The results were stunning. 30% of Delhi's population had antibodies, which means 65 lakh people in Delhi have already been infected by the China virus. And if we have 4,700 people who have died, sadly, because of the China virus in Delhi, the infection fatality rate is to the tune of 0.07% only. So you will agree with me that a disease which kills less than 1 in 1,000 people who are infected is nothing to be scared about. Yes, of course, we should be alert. We should be aware of the fact that we have a virus which can infect us, and there can be serious ramifications, but this is nothing to be terrified about. And we should, of course, keeping in mind that we need not be frightened of the virus, still be on our guards. We should not be reckless, which means that we continue with the hand washing program, we continue with some social distancing, and if required, wear a mask in a crowded place. Now, these simple things have to be kept in mind in order to prevent further number of cases. Now, the number of cases, I understand, have been 4,200 yesterday and about 4,100 day before in Delhi. Now, these are just cases. This does not mean that these people are actually infected. Now, this also I have explained in my earlier videos. Now, a positive case means that some genetic material, a bit of a dead genetic material, has been picked up by the PCR test. Now, in Delhi, 60,000 tests were done yesterday, of which only 15% were the RT-PCR tests, 85% were the quick gene assay tests, which are not very specific. Now, of course, you could turn around and say that maybe we have a lot of false negatives also. Maybe we are not picking up cases. But that argument is not very strong, because I've begun by saying that we already have a serological data of 4 weeks back, which clearly shows that 30% of Delhi's population has antibodies against the COVID-19 virus, against the China virus. And if the testing was done again, this number is bound to creep up higher. So instead of 65 lakhs, we probably would have 80 to 85 to 90 lakh people infected by this virus. And the fact still remains that we now can handle this virus much better. We have some drugs at our disposal. We also have certain approaches at our disposal. We know how to use oxygen. We know how not to use a ventilator. We know how to use an antiviral, and we know how to use a corticosteroid. We also know that convalescent plasma may reduce the infectivity and may reduce the days of symptoms in these patients. So all in all, we are now better prepared, and I don't think there is a second wave, nor a second wave would come, because we already have people who have been infected. The number of cases which we are picking up now may be areas which were virgin, where the disease has not gone in. And this would, of course, be also for the country in areas which were rural or which are rural in nature, and the disease would slowly and gradually creep in there. But I have my doubts about these tests. I have my doubts whether these tests indicate that the person who has tested positive is actually infected, is actually carrying a virus which can infect you and me. So which begs the question as to why, or why would you isolate such a person, or why would you quarantine the contacts of this person, knowing very well that there is a very strong chance that this person is non-infective, because this would then compromise that person socially and would compromise that person financially. But of course, there is no easy answer to this, but the fact remains that the infection fatality, the infection death rate is very, very low. It is less than 0.07% in Delhi. Now, this should satisfy you, but please do not lower your guard. You must not become complacent. You must keep on urging your colleagues, your friends, and even the strangers you meet, without, of course, getting into an altercation, that they should wash their hands as frequently as possible, and that they should keep some distance between another person. Now we move on to the other thing, and that is the RT-PCR test itself. And this also I mentioned earlier, that no laboratory in this country, or I think in the United States, gives us the cycle threshold. Now remember, if we amplify this if we amplify that genetic material, if we multiply that genetic material by 40 cycles, there is a very, very strong chance that we are picking up just remnants or just bits and pieces of genetic material which is non-infective, which will not infect, which means the test is not specific enough. The number of cycles should be 34 or less. In fact, a lab which tells you that their RT-PCR test was done with only 30 cycles would be the most accurate. That would possibly or probably give us an indication of an actually infected person. And apart from this, I must tell you that there is data, there is adequate data from Germany, from Singapore, and from South Korea that the virus ceases to be infective after 7 days. In fact, epidemiologists in Germany are suggesting that even the duration of quarantine or isolation must be reduced from 14 days to a week or only 5 days. Because after 5 or 7 days, if you still harbor this virus, the virus is not ineffective. So there is a lot of food for thought. We must be careful. We must always analyze data which is presented. We must especially be very alert with the newspapers which keep talking about this deadly virus. They keep repeating the deadly virus which has invaded our country. This is not a deadly virus. Yes, it may kill, half a person, or 1 person in 2,000, but by any standards, this is not a deadly virus. And this has been proven again and again and again by data across the world. Now we move on. From COVID-19, we should go to some more cardiology. And it is important because you all know that we have enough information that if a person is having hypertension, and by and large in the Western world, as also in India, in the adult population, almost 15% of people have high blood pressure. Maybe 20% of people have high blood pressure. When you have high blood pressure, and if you have COVID-19, you are at a higher risk for complications. That has been well established. Hypertension, obesity, diabetes, heart disease, heart failure are all risk factors for greater or more complications when infected by COVID-19. So some time back, there was a big news that a class of drugs which are used very commonly in patients of hypertension and in heart failure could be risky in patients of COVID-19. The reason given was that the virus of COVID-19, the China virus, penetrates our cells by a reception committee called the angiotensin converting enzyme 2, right? The virus has to attach itself to the reception body, that is the angiotensin converting enzyme 2, and only then can it penetrate our system. Now, some scientists raise the point that a class of medicines called angiotensin converting enzyme inhibitors and angiotensin receptor blockers, the ACE inhibitors and the ARBs, could be dangerous if continued in patients of COVID-19 because they increase the levels of ACE2, right? Now, the ACE inhibitors are medicines that prevent the conversion of angiotensin 1 to angiotensin 2. Angiotensin 2 is the bad guy. He is the villain. Angiotensin 2 constricts the arteries and the veins in our body. Angiotensin 2 prevents good urine output, and therefore it increases the fluid in our body. It also induces the production of spironolactone, and by all these measures, it increases the blood pressure in the body. This is angiotensin 2. So we have medicines which prevent the formation of angiotensin 2, also called ACE inhibitors, and we have drugs called angiotensin receptor blockers, which prevent the action of angiotensin 2. All right? Now, as I've said, certain scientists raised the possibility that these drugs could elevate angiotensin converting enzyme 2, which is responsible for the fusion of the virus to our cells, which actually promote or accept these cells are the gateways. And because these drugs, which are used very frequently in hypertension, because these drugs raise the levels of ACE2, they would make these people more vulnerable to infection and make them more vulnerable to the complications of the virus if infected. But fortunately, we had observational data. One was from China of 1,100 COVID-19 infected people. Of these 119 infected people, 1/3 were suffering from hypertension. Of these people who were suffering from high blood pressure, 1/3 of them were on ACE inhibitors and angiotensin receptor blockers. And the finding was that as compared to the people who were not on ACE inhibitors and angiotensin receptor blockers, who were on other drugs like diuretics and calcium channel blockers, the people who were on ACE inhibitors and ARBs, they had no difference in the complications of COVID-19. They were not found to be more susceptible to COVID-19, and above all, there was no increase of death in people who were on ACE inhibitors or ARBs as compared to the hypertensives who were not. The other big study came from Denmark. This included 4,500 people. 20% of these people were on angiotensin receptor blockers and ACE inhibitors. Again, the researchers concluded that despite the fact that people of hypertension who were on ACE inhibitors and ARBs, this cohort, this group of patients did not suffer more dangerous kinds of COVID-19, did not suffer greater complications, and did not suffer more mortality as compared to people who were not on these drugs. Now remember, these drugs are very important because they help you in hypertension. They also are very good drugs to prevent renal outcomes. They protect the kidneys, particularly in people who have hypertension and in diabetics. And these drugs actually reduce mortality and improve quality of life substantially in people who are suffering from heart failure. So the good news is that if a person is on an ACE inhibitor or an angiotensin receptor blocker, and if the person is already suffering from hypertension, there is no need to stop these medicines. Now, these were observational studies, so there was still some lingering doubts about these drugs. But now we have a randomized trial. This is the first randomized trial on ACE inhibitors and angiotensin receptor blockers. This was presented in the European Society of Cardiology meeting held a few days back in Amsterdam. And this is called the Embrace Corona trial. This has about 650 people already on ACE inhibitors and angiotensin receptor blockers for hypertension. And the important thing is that 85% of these people, of these patients, were on an ARB, an angiotensin receptor blocker. That means they were on either losartan or telmisartan or candesartan or irbesartan. So remember the term sartans. So 85% of these 650 patients of COVID-19 were on an angiotensin receptor blocker, and 15% were on an ACE inhibitor such as lisinopril, ramipril, enalapril, and captopril. Now, the researchers, they randomized these patients into two groups. In one group, they stopped the ARB or the ACE inhibitor. And in the other group, they continued with these medicines. They stopped the medicines for a month. And what did they find? They found that there was no difference in the clinical outcomes, and also that there was no difference in mortality, whether you stopped the ACE inhibitor or the angiotensin receptor blocker, or whether you continued with them. Now, this is very good news. Remember, this is the first randomized trial on these drugs, and the message is clear, despite the fact that this is a small study and the follow-up is also of a shorter duration. But if a person is on an angiotensin receptor blocker, or if that person is on an ACE inhibitor, if that person gets infected by COVID-19, there is no scientific reason to stop these medicines. Now we move on to another bit of science. Now this would be pure cardiology. This is not about COVID-19 at all, but I am fascinated by this new class of medicines, the SGLT2 inhibitors, the sodium glucose cotransporter 2 inhibitors. Now these drugs were primarily used for diabetes. Now, the story of diabetes is, for years we have been using drugs which reduce blood glucose in diabetics. But it was found that, these drugs did not actually improve cardiac outcomes. In fact, some drugs like pioglitazone or rosiglitazone actually increased mortality in patients with diabetes because of increased heart attacks. So therefore, the companies began another round of research, and they came out with these two classes of medicine, the glucagon-like peptide receptor analogs and the SGLT2 inhibitors. Now I will speak about the latter. The first big study was the EMPA-REG trial, which was published 5 years ago and which was, I think, presented also in the European Society of Cardiology. This included more than 7,500 patients of diabetes, and the remarkable thing about the study was that all these patients, almost all of them, had some underlying cardiovascular disease. 50% of them had a previous myocardial infarction. That means 50% of them had a heart attack, 20% had peripheral arterial disease, 25% had a previous stroke. Two-thirds of these people had coronary artery disease, which means they had either unstable or stable angina. The mean age was around 61 years. The mean HbA1c, that is the glycated hemoglobin, was about 8.1%. And almost all of them had had diabetes for the previous 10 years. The patients were followed up for almost 3 years. In fact, more than 3 years. And 10% of these people had heart failure. 90% of these diabetic patients had no heart failure. The results were staggering. The numbers were fascinating. It was found that there was a reduction in cardiovascular mortality by 38%. Now that's a huge figure. The absolute reduction was more than 2%. The relative reduction was 38%, which had never been seen before by any class of anti-diabetic drug. The reduction in all-cause mortality was by 32%, and the reduction for hospitalization for heart failure was to the tune of 35%. Now these numbers are big, 38%, 35%, and 32%. Now we have never seen these numbers before. So there was a clear signal that empagliflozin, this study used empagliflozin, an SGLT2 inhibitor, in a dose of 10 milligrams, 25 milligrams, and the third group was the usual group who were on usual anti-diabetic medication. And after a follow-up of a mean of 3 years, it was found that there was a substantial, significant reduction in cardiovascular mortality, in all-cause mortality, and hospitalization for heart failure. The other thing was that there was a clear signal that renal outcomes suggested by a drop of 50% in the GFR, by an increase of creatinine by 100%, by the need for dialysis, and even death because of kidney disease was reduced by as much as 50%. So the renal outcomes were also excellent by empagliflozin. The side effects were minimal. The only significant small side effect was fungal infection of the genitalia. Otherwise, there was no increased amputation, acidosis, or fractures in the treated group as opposed to the control group. So, encouraged by this, the researchers then went on to do another study, which was published and presented again in the current 2020 European Society of Cardiology meeting in Amsterdam. And this I have spoken already earlier. This was the Emperor Reduced trial. This time they took 3,700 patients of heart failure. Now the important thing is that they took 3,700 patients with heart failure. Half of these were not having diabetes, and yet showed that over a period of as early as 16 months, there was a reduction in hospitalization for heart failure and cardiovascular mortality by 25%. There was a reduction in hospitalization for heart failure by 30%, and there was a reduction in the deterioration of kidney function by 50%. Now, all these three values were significant statistically. So, now the other important thing is that the Emperor Reduced trial used a dosage of only 10 milligrams of empagliflozin. So the signal is clear that if you have diabetes, or if you do not have diabetes, and if you have an underlying cardiovascular problem, or if you do not have an underlying cardiovascular problem, the use of an SGLT2 inhibitor will protect you from damage to the heart and also damage to your kidney. Now, there was a meta-analysis published because the earlier trial of an SGLT2 inhibitor in heart failure was called the DAPA heart failure trial, which was published last year in the New England Journal of Medicine, and which again was presented in the ESC, in the European Society of Cardiology meeting held last year. And that had about more than 4,000 patients followed up for 18 months, which again showed a significant reduction in mortality and hospitalization for heart failure, and also a reduction in the decline of kidney outcomes. So the meta-analysis, which has been published in the Lancet a few days back, has combined these two trials, the empagliflozin, EMPEROR-reduced trial with the dapagliflozin, DAPA heart failure trial. So now we have almost 8,500 patients with heart failure, and the follow-up is the same, about 1.5 years, and we find once again that there is a significant reduction in cardiovascular mortality of almost 15% and a 25% reduction in hospitalization by heart failure and cardiovascular death of 25% and a 50% reduction in the decline or the outcomes of kidney function. So we are now on more or less solid territory with the SGLT2 inhibitor. The advantage of an SGLT2 inhibitor is that it is a tablet. It can be given once a day. The side effects are minimal and which can be easily tackled. The data is rock solid. If not rock solid, it is substantial. And the other important thing is these drugs are being manufactured by Indian companies, and the drugs are freely available in just about every city of India. So to round up, to sum up, I will conclude by saying that we have data that a significant number of young athletes who have been infected by COVID-19, despite being asymptomatic or mildly symptomatic, do have some lingering residual effects in their hearts. So one has to be careful in permitting them back to competitive sports. And this lingering myocarditis can be checked by a cardiac MRI. We also have data on the cases and the serology in Delhi. When we do the calculation, the case mortality rate is as low as 0.07%, which is actually very, very low. Remember, I am a cardiologist, and I know that if 1,000 people have a heart attack, and if they are not treated, 500 of them will die in 24 hours. All right? So that is something really serious. The other thing which I have spoken to you about is the fact that if a person is on an ACE inhibitor or an angiotensin receptor blocker, there is enough evidence now that such a person, despite the fact that such a person is infected by COVID-19, such a person should not stop treatment. Based on observational data from China and Denmark and from this trial, the first randomized trial which has been presented at the ESC Amsterdam 2020. And of course, we have this new class of drug which has shown very exciting potential in diabetics, in non-diabetics, which originally were for diabetes, for lowering blood sugar. They have been found to reduce the impact of diabetes and also non-diabetics, the impact of on the heart and on the kidney. If a person has an injured heart or if a person has an injured kidney, one drug of choice would be an SGLT2 inhibitor, especially if the person is a diabetic. Now, with that, I will finish. I will round up. Please have a good Sunday. And if you think that what I've said is of some value, do press the bell icon and do share this with all your friends and colleagues. Thank you very much.